MEC, honorable members. Thank you. Just check testing. Let me see. Thanks, Chair again. MEC, honorable members, HOD, and colleagues. May I request to go to slide 9? We'll start from the departmental performance areas. The other pages are introduction and preamble to what we've discussed previously. The APP has 69 performance indicators. 53 of these have quarterly targets, but we do note that we monitor all indicators on a quarterly basis. For the period July to September 2024, 32 of our targets were met, which equates to 60.4%, and we do note an improvement from quarter 2 of the previous financial year. On slide 10, we look at the overall performance per program. In program 1, 3 out of the 4 indicators were achieved. Program 2, 18 out of 29. Program 3, EMS, 1 out of 2. Program 4, hospital services, 4 out of 7. Program 5, tertiary and central hospitals, 3 out of 7. Program 7, healthcare support services, 2 out of 2. This is the pharmaceutical indicators that the Chair was referring to. Program 8, 1 out of 2. Then on slide 12, we take members through individual programs. In terms of program 1, we're reporting on e-health, percentage of suppliers invoices paid within 30 days, and the proportion of expenditure paid to business owned by a woman. So we've achieved the indicator in terms of e-health. In terms of percentage of suppliers paid within 30 days, we're sitting 66.7%, and we've achieved the target around expenditure to business owned by a woman. On slide 13, we give you reasons in terms of achievements, challenges, and interventions. We do note the milestones achieved on e-health are reflected in the slides that follow. And we've seen increased compliance for female business owners to competitive bid offers. The department has cash flow restrictions, therefore reducing the number of supply invoices that can be paid within 30 days. In terms of interventions and requests, if there's additional funding is required for the department to disperse payments timelessly. We go to slide 14. We list the various e-health milestones achieved in terms of training of the end users, equipping facilities with computing equipment, in terms of the secondary network to improve connectivity within the facilities, as well as digitizing of paper files within the facility. We've employed close to 256 interns to assist with scanning of these patient paper files. We continue on slide 15, and we note that we've employed 11 system administrators to manage the e-health rollout as well as support. We have 45 modules that have been completed in the system and is being deployed progressively to be used by facilities. There's been various existing systems that have been integrated in e-health, and those are listed on page 15. On page 16, in terms of Program 2 District Health Services, when we look at the improved patient experience of care, we do note that we've, in terms of patient incidence disclosure rate, we're sitting at 89.9%. In terms of reporting on our incidents, SAC1, within 24 hours, we're at 94.1%. On slide 17, we note that whilst PSCs are reported to the supervisor within 24 hours, we do have delays in terms of capturing for some of these incidents, largely because of the connectivity challenge that facilities do experience. In terms of interventions, there'll be in-service training on PSC guidelines. We'll continue in quarter 3. Training videos will be shared with district coordinators to cascade training, and we'll continue to monitor timing of reporting as per PSI guidelines. On slide 18, in terms of the sub-program HIV/AIDS, STI, and TB, which is the HAS program, We do note that our indicators achievements for the TB is mostly below the target, whilst in terms of the success rates for TB patients, we're sitting 75.8%, and HIV positive 15 to 24 years ANC rate, excluding ANC rates, around 1.7%. We continue with sub-program HIV/AIDS, STI, and TB. We note again that there are some TB indicators that the department will continue to work to improve. On slide 20, there is improved in terms of linkage of drug-sensitive TB clients, which are down referred from hospitals. Disclosure remains an important factor in not meeting child suppression targets, and there is a high loss to follow-up amongst men. There are various interventions to improve the HEST indicators, including Know Your Child strategy, scaling up of access with psychosocial support from social workers in the department, social development and partners to disclosure counseling. We're implementing the loss to follow-up strategy called Welcome Back strategy, and there's a focus on men's health, where we've increased the health facilities providing this particular service to improve adherence and support to men. In terms of slide 21, for maternal, neonatal, child, women's health and nutrition indicators, we note that there are positive results for all the indicators in terms of reducing mortality and morbidity amongst children. That's slide 21. This continues in slide 22 in terms of maternal health, as far as delivery to 10 to 14 years, antenatal care visits, postnatal care visits, as well as testing children for HIV. On slide 23, the immunization program, there are catch-ups that needs to happen in terms of improving the performance, as well as for cervical cancer screening coverage. The interventions are reflected on slide 24 in terms of implementing catch-up drive activities and monitoring vaccine stockouts in the facilities. We also note here that one of the challenges in terms of cervical cancer screening is the cyber attack that happened to NHLS, where NHLS requested the department to only supply bloods that required emergency testing. On slide 25, in terms of mental disorder treatment rate, the target has been achieved, largely because of the implementation of standard operating procedures on screening and treatment initiation. On slide 26, we reflect on EMS medical services. We do note that the response times in urban areas have been met at 42.7%, whilst the response times in rural areas is slightly above the target, sitting 47.1% compared to 48%. In terms of the achievements, we are implementing fleet management interventions to improve turnaround times for maintenance of vehicles, and this is seeing positive results in Amajuba, eThekwini, Lembe, and Ogu districts. Other experiences are challenged with regards to the fleet management contract, resulting in delays and extended downtime of emergency vehicles, and there is an issue of budget constraints to meet to be able to purchase additional vehicles. However, we do note that there's a provision to procure 42 new ambulances, 8 PPTS vehicles, as well as 2 rapid response vehicles. And there's a constant engagement with the service providers to increase turnaround times for maintenance. Slide 28, we report on provincial hospitals. We note that at provincial hospitals, we're seeing positive results in terms of morbidity and mortality. And we did speak about the improving client experience of care, as well as reporting incidents within 24 hours. The interventions will remain the same in terms of training on PSC guidelines, as well as increasing cervical cancer screening awareness campaigns. On slide 30, we're looking at tertiary and central hospitals, and we note that the PSIs, we're doing well in terms of closure rates at the tertiary hospitals, as well as pneumonia death under 5 years. There are some challenges around diarrhea death, as well as SAM. And we're seeing the complications in terms of deaths from severe acute malnutrition, largely due to comorbidities such as cardiac conditions, cerebral palsy, and late diagnosis of HIV. The interventions, we're looking at continuing with IMC training for early case detection of illnesses in children, as well as inpatient management of SAM. On slide 32, we reflect on tracer medicine stock rate at PPSD, as well as the facilities and their positive results in terms of managing the stock, largely because of stock rationing and redistribution of stock to facilities with low stock levels and monitoring the stock in the facility itself. In terms of Program 8, health facilities management, we note that the percentage of preventive maintenance expenditure is under the target, largely because money had to be moved around between category A and projects, and these breakdowns are due to power outages that we experienced during load shedding. So there's a catch up in terms of maintenance as far as this is concerned. And Chair, when we reflect on slide 35, we're showing you an year-to-year performance. And we do note that there is a gradual increase from 2017-18. We're sitting at 58.8% in the last annual report. And we also note that during COVID, there was a decrease in terms of target achievements. In general, Chair, the department does constantly have plans to improve the healthcare service delivery system, as well as through reviewing strategies and working closely with all stakeholders. With that, I thank you, Chair.
Thank you very much. Honorable members, before I ask some questions, the floor is yours. Honorable Mavimbela.
Thank you very much, Chairperson. We welcome the opening remarks that have been made by the MEC. We didn't want to come in, but we appreciate your presentation, MEC, and indicating on some of the challenges that you are facing as the department. Hopefully all the challenges that you have raised, they will be mitigated. We are also welcoming the presentation that have been made by the officials, starting with the financials and the non-financials. I've got just two questions, Chair, to raise in terms of the presentation. I'm going to ask both from the financials and non-financials. The first question, it's pertaining to the over expenditure. I just want to understand from the department, what is the mitigating plan in order to mitigate the unauthorized expenditure? Why I'm raising this question, Chair? I'm raising this question, Chair, because we have adopted the APP of the department. And in the APP that we have adopted of the department, we have the reduced performance indicators. And those performance indicators are not being achieved. So it doesn't tally. There is over expenditure, the indicators are not achieved, whereas they are being reduced. Really, it's not tallying. Hence, I am of the view that we can be giving the strategy in order to mitigate the over expenditure and be assisted in order to understand why the indicators are not being achieved, because you can be not achieving the reduced indicators, because by not achieving those indicators which are being reduced as compared to the previous years, it means there is something that is not done well in the department. So I think these questions goes together. It marries the financials and non-financials. On the side of the financial, we are having the over expenditure, but with the indicators, we are not achieving your indicators. Thanks, Chair.
Acting HOD, who is going to respond to that?
Thank you, Chair. The CFO will respond to the mitigation plan on the over expenditure, and I will respond on the non-achievement of the indicators.
Can you then proceed?
Can you start, CFO?
Thank you, Chair. Good afternoon, Chair. Good afternoon, honorable members. I will start on the mitigation of unauthorized expenditure in light of the reduced APP. We have tabled a number of activities in other structures and oversight bodies that talk to how we're going to go about managing the cost under the circumstances. However, there is always those overheads that don't necessarily reduce in variance with a number of targets that are set. I'll give you an example. Your property payments, the number of beds, your cost of employees. So your variable expenditure will only vary with what you have stopped doing. If you still have same number of beds, you're not gonna change. You're not gonna reduce. That doesn't cut your expenses that you face to incur. So what we have done is we have looked at what else can be achieved. Maybe let's cut down, for example, repairs and maintenance that are supposed to be of maintenance purposes, and look at what is necessary, look at the damages that occurred, and also negotiate extension of payment terms to our suppliers. There is more of delay, but to link the two is not necessarily the case. The fixed overheads remain fixed. Thank you, Chairperson.
Thank you. I will respond to why the indicators are not achieved despite the targets being reduced. Firstly, we would like to appreciate the consideration by the Health Portfolio Committee to reduce the targets on the APP. We agree that there are indicators that we are achieving, but if we are not achieving, but if we look, most of those indicators are around programs or interventions that have got a lot to do with our preventive and promotive health approach in terms of our public health, which means they require that ourselves as a department, we have strong advocacy and social mobilization programs that would mobilize communities around adopting a healthy lifestyle program and a preventive approach. If you look at indicators like your immunization coverage, your cervical cancer screening, your mortality and morbidity around TB, the most important strategy and approach there would be to deliver a very strong preventive and promotive program that would ensure that communities, even if people are screened early for diseases, they are protected from diseases through immunization of children, and also they are screened early for those diseases. Hence, then the outreach programs that we have, like your Isibhedlela Kubantu, your men's health programs, and other preventive and promotive health programs. So we are strengthening those programs in order to achieve those targets, because by the time communities come to healthcare facilities, they're already infected and affected by diseases. But if we are strong in our promotive and preventive and promotive approach, we are going to achieve those targets. So in this financial year, we are going to be strong as a department in implementing an integrated approach in terms of preventive and promotive health programs. We've already set up structures at provincial level, at district level, where the Department of Health, together with other government departments in the social cluster, your Department of Education and DSD, your stakeholders, we are going to rally around this preventive and promotive health strategy, driving these programs like Isibhedlela Kubantu, men's health programs and other programs to ensure that we improve our coverage in immunization, improve our coverage in terms of cervical cancer screening and other critical programs here to reducing teenage pregnancy, whilst at the same time ensuring that our primary healthcare services are functional because they are part of that interventions. Thank you.
Honourable Member, any follow-up?
Chair, it's a recommendation that I want to put forward to the department, because the over expenditure also talks to unauthorized expenditure. So we would love to see the full funded or the full spending plan for the remainder of the year, so that we will know where they will realize the savings going forward, because we understand that you are facing the challenges of budget cuts. And in the situation that we are in right now, really, we are shivering what is going to happen going forward. So would love to see that plan going forward. How are they going to plan going forward in order to mitigate all these challenges on top of what the acting HOD is presenting before us? Thanks, Chair.
Thank you very much, Honourable Member. Before I go to the next Honourable Member, I think Honourable De Boer was before you, Honourable Doctor. I think you have made a proposal regarding expenditure going forward. So I think let's crystallize that and let's find it as a resolution. Would you just want to retable for us how you want that to be done? As a formal proposal, we'll have it seconded and it will become a resolution of the committee.
Chair, I think the technical team will be able to crystallize it, because I've already made my point that the department will come up with the full expenditure plan going forward, where they will see the savings going forward, so that the department will continue to function under the circumstances that they are faced with of the over expenditure, which is unauthorized in some instances. Thank you, Chair.
Would you accept a modification? Because I was thinking along the same lines as you, and I was going to raise it, because you will recall that the department did present to us a, how can I put it, a cost-cutting plan. We were not too thrilled with it. We made some input, as a result of which one of the items is on the agenda today. Can we then add to your proposal to say that, or amend it to say that they must come back to us with a more fleshed out program, including your point regarding the cost-cutting measures, and basically give it to us as a breakdown, point by point. We don't want, even if we have to spend a whole meeting listening to you, we don't want you to give us this big plan and then we just, it's just up in the ether. We want to see how you are exactly going to implement that. So if you tell us that we're going to cut the purchase of ambulances or transport vehicles by 50%, then we want to see what is the impact, what is happening. We want it properly broken down. Would you accept that amendment?
I'm not a technocrat, Chairperson. I think when it is presented, I will find out whether it's captured the way I want it to be captured, because I'm not a technocrat, but I know what I want to say and I understand, because I was talking to the performance indicators that are not achieved. There is an over expenditure.
Okay.
The over expenditure is also unauthorized, and we are in the second quarter. There is a third quarter and a fourth quarter.
Correct.
So I want the department to come up with a plan that will be saying, here we are, in order to mitigate these challenges, there will be savings that will mitigate these challenges that you have identified as the portfolio committee. So I think maybe what you are proposing will come in that. Thank you, Chair.
Thank you, Honourable Member. So I'm taking it that in Kolani's notes, he's mincing those two things that will end up giving us the same effect. Are there any objections? None. Thank you very much. Let that be a resolution of the committee. Honorable De Boer, you were next.
Thank you, Chair. My question is around the fleet matters. It's not only affecting the EMS, but I see here in the report that it's also affecting the health facilities management. Now, when we did oversight at the hospitals, there were some EMS officials, and they were telling us about their challenges in terms of maintenance and repairs to the fleet that they run with. Can we ask fleet to give us regular updates, possibly monthly or even quarterly updates on the vehicles that are not operational? They are not operating, so they're in for maintenance or service or breakdown or accidental damage, so that we can keep an eye on what is actually happening with fleet management, and also the challenges, how long they've been there, why they're there for so long, etc., so that we can try to understand what is happening with our fleet in the department. Thank you.
You want to respond to that? The MEC wants to respond to that. MEC?
No, thank you very much, Chair. Chair, I see that Honorable De Boer is kind enough to allow us to negotiate. She says monthly or quarterly. So I I want to make a request that can we make it a quarterly report, and maybe starting next report being due in this month, say maybe end of on the
11th
of February. That's fine. So that's the first report, and then we make it quarterly after that.
Thank you very much. In that report, MEC, when your department sends us that report, one of the challenges that we found during our oversight visits was particularly around West Bank. So the extended delays, if I'm not going to allow the Honorable Doctor to talk about it, because he will talk about it for 2 hours. In fact, he visited in Newcastle 2 places there, and we found the vehicles parked there, delays from West Bank. So I think in your response to us, we're meeting again on the 11th. You are not coming to us. We are going to your facilities. But if the report is ready, you can send it to the committee, and we can just table it for the consumption of the members, and then we can interrogate it at a point where we meet with yourselves. I think this is information that is readily available, but not necessarily just around the EMS fleet, because you have a wider fleet other than EMS, and the service providers are the same. You're still dealing with West Bank, and you're still dealing with the same workshops, and you're still dealing with the same things. On that note, honorable members, the MEC will know that I have sent her some parliamentary questions around vehicles that I observe.
Yes.
So she has seen them and she responds to me. So I would go to the pavilion, for example, if I'm there and then I find an ambulance. I did find one. I sent you the question. This character had, he was doing shopping. So he had the grass cutter there in the ambulance, and, he bought it maybe from Game when he's supposed to be serving citizens. I understand if you go for lunch because you have to eat. But, you go and park there at the mall and take your time, so if you yourself observe these things, use that, because it then allows for accountability. We're not going to shout at the MEC. She wasn't driving the vehicle. But we want that person who was driving the vehicle and not serving the public to be whipped. So I think it's reasonable. Honorable Dubur, you accept? Honorable members, acceptable? Done. MEC, over to you.
No, thank you very much, Chair. We accept that guidance. The report is there. In fact, we will speak a little bit to what you've just indicated on the report about EMS. Yeah, but we will then give you a full report before the 11th. I wanted to also indicate, Chair, just as a by the way matter, that in December we dealt with two issues, and by some luck they were a day after each other. I think it was just before the 24th, the Premier sends me a message from someone who has been observing one of our ambulances in town next to a shipping. And the ambulance had been standing there for close to 4 hours. And Premier says, the unfortunate thing is that when these messages came to him, he ignored them because he was busy. And by the time he realized what they were and sent them to me, the vehicle had gone. But what was good about his reporting is that it gave me pictures, it gave me times, it gave me the ambulance registration. Therefore, we were able to pick up who was driving that ambulance at that particular time and investigated and dealt with the matter. Following day, the provincial secretary of the ANC, who is working around town, finds an ambulance in town that is being used to ferry around building material. And he takes a video. So as they are putting the windows into the ambulance, he's standing there and he's taking the video. So he sends that to us as well and takes the same thing, ambulance number and so forth. And when we investigate that one in particular, we actually discover that this ambulance is buying material in Durban, but it's an ambulance that belongs to Uku district. So the people of Uku are waiting for an ambulance which can service them. But that ambulance is not even in the vicinity of where it's supposed to be servicing. So at least there, when you give us information like that, we're able to deal with the matter on the spot. And I also want to make a request, Chair, that members might not want to wait for a question to send us a question. Through you, they can just send whatever evidence that they get and send it to us immediately, and we're able to make proper investigations.
Yeah. Thank you, MEC. The reason that I resort to questions and advise members to questions is that there is a record against that person. So whilst you will act, and we can send it to you to act, the question forms part of a trail of evidence against the person, because when you receive the question, you send it to the district for response. And we have found in the past that they lie. And that lie is your evidence against them. So you let them incriminate themselves. I think you know about those things in law. So any follow-up from yourself, Honorable Dubur? Nothing? Honorable Dr. Mtetwa, you are next. You switch on your mic, please.
Thank you, Chair. I'm partly covered in my 3-4 questions. One, the cost-cutting measures. I think we will wait for the report to detail what's in it. Maybe just also to get some clarity. Remember that we did have asked questions to the previous HOD regarding the cost of consultants and the cost of rentals that the department is having. I'm seeing that on the report still. I'm hoping that on the cost-cutting measures it will come, because it gives us clarity of how much money is there or being used there, then how much money can you spare, especially around the issue of properties and rentals. I know that as long-term plan, we need to also look at that to say, what can we do? Because the department is spending quite a significant amount of money on rentals for the offices and all those things. And then the issue of fleet management, I think is detailedly covered. Then on the slide 20 to slide 22 on the non-financials, we know that as a province, we have a serious issue of shortage of social workers, and we are seeing these results now when we are losing patients through tracing and we're kids through immunization strategies because we don't have enough social workers to assist. My question to the department was, do we have social workers that we employed, not that from DSD, and then the ones that we have, how many vacant posts for the social workers do we have against what we need so that we can then see if it does have an effect on us failing in losing patients towards the TB. I think that's just it. Thank you.
Thank you, Honourable Member. I don't think before the department responds, the acting MEC and acting HOD will direct who will respond to that. But I don't think it's only social work, because the department structure, they will explain to you who does that in terms of tracing, and it's not social workers, but I think they'll respond to that. MEC, acting HOD, who will you respond, MEC? Okay.
Thank you, Chair. Acting HOD will indeed respond, but you are right, Chair. Our tracing and all of that is not conducted by social workers. We do utilize the services of social workers in certain areas, but where we are unable or can't afford social workers, then we use different categories of health workers. Mrs. Msma? Thank you, MEC, and thank you, Chair. In terms of tracking and tracing of patients, we have the community health workers who are at the community level that track and trace patients. Also, we have a cadre of workers that were employed at the initial phases of implementing the HIV and AIDS programs, who are called lay counselors. Those are equipped with a short program on counseling. But over and above that, we have also trained our staff on adherence support and counseling so that they can counsel and support our patients in terms of treatment adherences. The social workers that we have in our healthcare facilities, over and above doing psychosocial support for our patients, assessing indigent patients and so on, provide mentorship and support to our lay counselors so that they could have, because they have got minimal qualifications in terms of counseling and psychosocial care. So our tracking and tracing is done mainly by our field workers, community health workers. We also have TB tracers that trace patients with TB. And this is also complemented by our support partners, the NGOs, who, as HOD had alluded earlier on, have linkage officers that actually support our community health workers and work with them in the tracking and tracing of patients. Thank you, Chair.
Any follow-up, Honourable Member? No? No other questions? No? Okay, my turn. So, acting HOD, I think what we're going to do, and MEC, and I think Golani must note this, we're having a problem. You see, you're giving us financials and non-financials. Some of the questions that arise here is because we don't get any information about your cash flow, right? So our budget analyst, in our discussions with him, he informs us that this information is like, I don't know if I know there's one medical doctor here. I don't know if there's anybody else here, but if you're delivering a baby with what we call shoulder dystocia, when the shoulder is stuck, the baby doesn't want to come out. It's a very difficult labor. It's like getting that to ask you for your cash flow is very difficult. You just don't give it to us. So we need to monitor your cash flow. This is our job, our part of our oversight duty, but getting that information from you is very hard. So we want to make it a standing item on our agenda, that you present your cash flow to us and that you send it to us in time so that we're ready to interrogate it. I know it changes daily. And I'm aware that Treasury has or is in the process of developing a tool where all departments' cash flows will be available at the touch of a button to those who need it. But we need it. This committee needs it. So I'm hoping that you can give that to us, right? Although we are just looking at the second quarter here. In our discussions during our briefing, one of the things that we noticed, and it came up here as well somewhere in one of the slides, was eThekwini, the healthcare facilities in eThekwini. So the healthcare facilities in eThekwini are not submitting the invoices to you, and they are then showing, or as a result of which in that particular area, there is some degree of under expenditure. Now, there are problems. Those facilities are being given money, and they are actually in a deplorable state. As a result of which, the facilities in eThekwini, whether you take Gandhi or Kans or any one of those, Wentworth, any one of those facilities, the OPDs are overwhelmed because people don't want to use those facilities. Now there's under expenditure on the one hand and deplorable facilities on the other hand. And it comes back to the point that the Honorable Mavimbela made about the disparity between these things in the first place. So I'm not asking you for an answer per se to say, look, what's going on? But you need to let us, you need to bring us into your confidence about the eThekwini health facilities. I remember in 2014 when I first came to this legislature, there was an undertaking at that time that those facilities would be provincialized. Now, I understand why they are not provincialized. We just don't have the money, right? So it suits the department to let them linger there, but it adds a burden to the department itself in terms of what the department then has to deal with. I think, some serious decision needs to be taken, one, but it needs to be based on evidence. So I'm asking that, is it possible for the department to have an in-depth look into the eThekwini facilities and come back to us and say, look, they have infrastructure challenges, they have these challenges, they have those challenges, because just as we have oversight of them, you have a greater responsibility over them. So, honorable members, can we ask the department to come back to us with a report on the eThekwini facilities? You can tell us how much time you need. You need 6 months, you need 3 months, you need 4 months. We're not going to pressure you. We're not going to put a deadline on it because it's a sensitive exercise. Because the moment you start doing this kind of exercise, you have politicians there who are a multi-party committee that sit and oversee this. And it is something I raised with that political leader last night on the radio program. I said, you coming here and you telling us about medicines, what are you doing? You see, because the impression created in the minds of the public is that there is a problem, but our facilities are burdened because of underperformance, budgetary and otherwise, financial and non-financial in those facilities. So I'm asking that you do that for us. So that's number one. If you look at this report on your financials, there is a common thread. One word everywhere. Every paragraph contains one word: over expenditure. Right? So the MEC started her remarks also about telling us about the 4.7 billion rand. She said 4.5. Then I thought, oh, has it come down? I said, oh, then I see it's, but sometimes the tongue slips. But okay, so we'll get you back with that report that the Honorable Mavimbela has requested, with what I've added in terms of your cost cutting, because we want to see how you're going to mitigate. So I don't want your response on that now. But what I do want a response on, and somebody will respond to it, is about your grant funding trend. Right, as of the second quarter report that you're presenting, it's not ideal. It's a little bit under. It's not at the 50% mark yet. It's about 48 point some odd percent. So we've already progressed beyond the second quarter. So you can tell me now, before that report comes, where are you? And we know that you do spend your grant funding. But what we don't want is that you come to the committee on the fourth quarter report when you do present it to us, and then we say, oh, you were responsible for fiscal dumping. Because then the CFO is going to get a lashing. So, or Mr. Mkhize, whoever is presenting at that time, but either or. So what we do want is that if you can just give us an indication of that now. So that's the other question I have. Acting HOD, when you responding to our questions, don't give us long-winded stories. We don't want to hear stories. We want the facts. We don't want stories that we leave the politics to the Honorable MEC. She will give us the stories and the politics, because if I start questioning you on half the things that you were saying earlier on, the MEC is going to get upset with me, but and the honorable members also. So we just want you to stick to the facts. Give us the facts, and then we'll go from there. Now, the Honorable Mtetwa has asked you about your use of consultants and all that. When you're preparing that report on your cost-cutting measures, make sure that it is a point that is included in there. Because it clearly states here, consultants for the improvement of audit outcomes. Now, you have a finance team, you get an unqualified audit, but we see here something that piques interest because it is adding to your expenditure, consultants. Tell us about it. I have asked in the previous term a question about it, but let's come back with it. I see here you have forensic investigations. Now, we know that forensic investigations are a matter for the Office of the Premier. If you can tell us today, it will prevent us from asking you for a report. If you can just tell us today about the number of forensic investigations that are ongoing, if you have an idea. If not, then we'll ask you to come back to us. So hopefully we can. Then again, you have consultants, business and advisory services. A lot of money has been spent there. I'm just going to go through them quickly. I think the issue of the targets that have not been met have been explained. The acting HOD has explained why you have not met your targets and all of that. But the committee does remain concerned that these targets are not met, because you tell us about, oh, you have these people that go out and these community health workers, and you have this cadre and you trace the TB people, and you tell us about all these people that you have, but the report tells us otherwise. You didn't meet the target. What is the use having them? You set these targets. We didn't set them. Then you don't meet them. Then we must condone reduction of the targets. Then they're still not met. So, okay, it wasn't under your watch, granted. But somebody here has got, the department is here, somebody's got to tell us, why? Why do we have this? What are the causes for these immunization figures not to be met? You're telling us you have people, you're telling us you have these awareness programs. If you don't have money for it and you have to cut it down, tell us that. So then we understand, okay, the target wasn't met because you couldn't have enough people to go out and do the work. Makes sense? So that is what we want to hear from you. So hopefully you're going to tell us, you're going to tell us that. EMS there's a couple of questions around it. We'll wait for that report. You'll tell us. Okay, those are my questions for now. MEC, do you want to shoot first?
Thank you very much, Chair. Chair, we will provide you with a report on the provincialization of eThekwini facilities. However, we can't afford to provincialize.
Chair, when I came in 2019, I was given a briefing that there was a decision, and I knew this because Umgungundlovu also had clinics, and they were quick to hand over and provincialize. And it took some time in eThekwini because there was some political unwillingness between the municipality. They were not willing to necessarily hand that over. So we started the process. 2019, COVID came, 2020, we abandoned everything else and focused there. Around 2020, end of 2022, we then started the process again to say, can we negotiate? We had formal meetings with both the mayor and the ESCO member that is responsible for this. During that conversation, it was quite good. They understood and we wanted to start the process. And then when we actually went out and started budgeting for it, we realized that it was unaffordable. We had already started taking over actually one facility, the CHC, Yagamakutane, Ketomena. Yeah, we took over the Ketomena facility and it was part of the process. Ketomena was going to be the first one in that financial year. The following year, we're going to take over about 5 clinics and you would do it incrementally because, again, we understood that once off was not going to be possible. But because of the challenges that we were facing financially, our plans had to be stopped like a dead break stop because really it just couldn't happen. But the truth of his chair is what you are saying. The clinics that are called municipal clinics are not even clinics at all. The state that they are in is just horrible. When you go and visit some of these clinics and you think you are going to be taking over a clinic, in essence, you are taking over a container which has holes in it and so forth. So if you say as a department you are taking over that clinic, you will be starting everything from scratch. All the municipality will be giving you is clients and land because we'll then have to build. Because what they use as clinics is very, very below our standards. But we will write a formal report and present, Chair. Thank you. TDG? Oh, acting HOD, sorry.
Yeah, thank you very much. I had many more things. Over to you.
Thank you, Chair. I will ask a CFO to respond to the grant funding expenditure trends, as well as Ms. Mngqithi will respond to the issue of the forensic investigations.
Thank you, Acting HOD, honorable members and Chair. On the grant funding expenditure trend, we are a bit delayed on the allocation and generalizing some of the expenses, and we are going to catch up definitely before the financial year end. Mainly the reason for that is we do receive NHLS and the municipality, eThekwini municipality invoices, but due to available cash that we have to spend on a periodical basis as and when it becomes available, we then allocate what is available to a number of suppliers and payables, and then with those that are relating to grants, we eventually catch up and update year in, year out. And we are going to fully utilize those grants according to the budget and for the purposes to which it was intended when they were granted.
Okay, I have no follow-up on that. Thank you for your response, CFO. Next.
Good afternoon, Honorable Chair, Honorable MEC, Honorable Members, HOD and colleagues. To respond to the question that was raised by Chairperson with regards to the forensic investigations residing in the Office of the Premier, We do have forensic investigations residing in our department, which was a matter which spoke to the cabinet resolution on a minimum anti-corruption capacity in all departments, whereby big departments or large departments had to have some kind of anti-corruption activity in their departments. So in conforming with that, the Department of Health then established its departmental investigation services. Hence, we have got departmental investigation services in our department. For that cabinet memo, it is Cabinet Memorandum 46 of 2003, which then calls for minimum anti-corruption capacity. And with regards to the investigations that we are conducting in the department, at the moment, currently, as at the end of the third quarter, 31 December 2024, we were sitting with a database of 342 cases, of which just during the quarter of...
Sorry, just say that figure louder. I didn't get the exact figure. 342.
42 registered cases on our database. Some of the cases have been finalized. However, some of them we would, through the Cluster Audit and Risk Committee, would request that they then be what's the right word? We would move them from the database, but we would store them such that we don't lose them, archive them basically. And just during the third quarter, we had 18 cases that were registered in our database, which range from assault, misconduct, nepotism, OR WOPs, corruption, HR irregularities, fraud, and SCM irregularities. However, with regards to I think, yeah, I don't know if you would want me to unpack some of the other cases that are on the stage of being finalized, but with that, just to give an indication that just in one quarter, we registered 18 cases, but we have got a database sitting with 342 cases, and we are reporting on the Cluster Audit Committee in the in-committee on the status of those cases. Thank you, Chair.
Yeah, we understand that you have 72,000 odd staff, so there will be a number of cases that will come your way. So, okay, thank you for the update. I'm sure that when we do regularly check on fraud risk and your preventive measures, as you will present to us in the next one, we will continue to ask for these updates. So when you do come, please have them ready for us in terms of the figures that will help us. Thank you very much. I have no follow-ups on that. Is there anything outstanding from what I said? No. Okay, there's an honorable member, the honorable committee is online, who has a question. Her hand is raised. Honorable member, I should say the screen is yours.
Thank you. Thank you so much, Chairperson. Greetings to the House. I must thank MEC and his team for presentation. And I thank the colleagues, including Chair, because most of the things that I needed, some of them were answered. I have a question because I think every cent counts, when it comes to the cost-cutting measures and the savings that we need as per department. I would love to ask area IT Uguti, how many ICT licenses do we have currently? And the other question is, we have blood bank and national health laboratories. I believe they are housed in the Department of Health facilities. I'm hoping that I'm current with this information. If it is so, are they paying rent? Because you are looking in terms of goods and services where they also receive the services of pest control, of this and this, of this and this, of which it's adding pressure in terms of the department. So my question in terms of blood bank and the lab, are they, if they are hosted within the department, are they paying rent? Are they paying for water and electricity? And yeah, maybe for now, that is what I can contribute, Chairperson. Thank you.
Honorable Member, NHLS, if I'm going to open that can of worms, it's going to require us to have an entire presentation on the NHLS and who owes who money and all of that. So
Okay.
I'm going to deal with the NHLS like this. I don't want it. I want through you, MEC and acting HOD, for you to prepare a report for us and forward it to us. So what we will do is we'll circulate it to the members. We will read that report on our own. And if you have any questions on the NHLS, then send those questions in writing through parliamentary questions to the MEC.
Okay.
Right. Because the problem with bringing the NHLS here is today is not the time to deal with the NHLS. Right? It's a challenge, yes, but it is not it is amongst the problems of the financials, but the entire debacle and MEC and acting HOD, the reason I'm asking for it in this manner is that we have new members. And members need to be capacitated, and the only way that they are going to be capacitated is if we get this information from you. For those of us that have grown white here, yeah, but still young, but we have an understanding of what was happening historically. But to capacitate the new members, we'll appreciate that you do give us that information, so members can interrogate it in their own way. So thank you very much. The next presentation is on the fraud risk prevention plan. It is a requirement in terms of our audit of the committee that it is presented to us. We're going to ask you to present it to us. There's not much in terms of questions that may be put to you, so take it easy, but you can present it to us. I don't want you to read it word by word. I want you to speak to it so that it is then formally before the committee. And then we got a more important report than what you are doing there in terms of the presentation on EMS that we are more interested in right now. Fraud and prevention, look, we can make lots of political comments about it, but let's just stick to the meat of it.
Thank you, Chair. Ms. Mngeti will present on the fraud and risk prevention plan.
Thank you, HOD. Honorable Chair, Honorable MSC, and honorable members and colleagues. I will be presenting the fraud prevention plan. It is more on talking to the committee with regards to the fraud prevention plan that we have in the department, that through the provincial, through the fraud prevention policy, the department has recognized that fraud and corruption undermines our values, vision, and mission. Hence, we are committed to a zero tolerance approach with regards to fraud and corruption. And with that, we have formulated some strategies whereby we do communication of fraud prevention information to all officials through fraud prevention advocacies, where we do trainings and workshops, and also we look at the fraud risk assessments so that we're able to identify matters that are relating to fraud and report on them on a timely basis. With regards to the prescripts that guides us, we are guided by the PFMA Section 38(1)AI of the PFM of the Public Finance Management Act, which speaks to the roles and responsibilities of the accounting officer of the department to ensure that there must be effective, efficient, and transparent financial and risk management and internal control in place. Hence, the fraud risk management then falls within the ambit of risk management. Together with that, Section 3.2.1 and Section 27.2.1 of the Treasury Regulations also speaks to ensuring that we do have the fraud risk management strategy included as part of our governance structures in the department. And also we have got our fraud prevention plan, which talks to fraud risk assessments as well. Basically, with regards to slide number 4, we are just defining what fraud is. Those schemes that are that may directly or indirectly impact the department, in that there would be measures that are done or practiced against the department, which include misconduct, mismanagement, and maladministration, which then present a significant risk to the assets of the department. And then the department has then formulated the principles of fraud risk management, which are communicated throughout the department. And as we speak on the intranet, we do have the fraud prevention plan and all other policies or governance documents that are talking to fraud risk management. We strive to break the fraud triangle, which is talking to motivation, opportunity, and rationalization. In that we
yes,
look
I am
at.
back. I'm back in South Africa, but I'm running around.
Can I carry on? Yes, we strive to break the triangle of a fraud, in that we know that the fraud triangle speaks to motivation, which is more linked mostly to greed, opportunity, where we have got poor internal control systems, and then we need to be able to ensure that those are enhanced, because when internal controls are poor, then there is a gap of whereby we would override the systems to make sure that, because there won't be any segregation of duties sometimes, and then you would find that one person would be responsible for doing a lot of duties, and then they would then see a gap, and then that opportunity then would realize into fraud and corruption. And the issue of rationalization, whereby we then say that, we justify ourselves that, we can carry out with fraudulent activities because the government has a lot of money, so why don't we just carry out the issue of fraud? Basically, with regards to the fraud prevention plan, it's the cornerstone of all the enablers that exist that support the implementation of fraud risk management at both the strategic and operational levels of the department. And this then comprises of policies, guidelines, and procedures, and this is represented in our fraud risk management process, whereby with the enterprise risk management, which is overarching, which talks to the Section 38(1)(a)(1), and also to the Treasury Regulations as to what is it that our guiding prescripts. And it's also defining the fraud prevention plan, which then has got principles of fraud risk management that are linked to it, 6 of them, which range from the fraud risk governance, the governance structures, the fraud risk assessments, the fraud prevention, fraud detection, the investigations, as well as post-investigation activities. The fraud risk governance basically is talking to the policies, the strategy, and the implementation thereof. And also, it also looks at the risk management philosophy, the oversight structures, the setting of the tone at the top, and also the responsibilities of all officials. Because at the end of the day, it's not just management that is responsible for fraud. It's all officials in the department that have got a responsibility of reporting fraud and also of ensuring that they stop actually fraud through the ethics workshops that would be presented to all the officials in the department. and also the oversight, the assurance structures like the internal audit and the internal control, whereby we would be able to look at the internal controls. If they're not working properly, then we would talk to them and be able to come up with the mitigation strategies that would assist in ensuring that the controls are enhanced. The fraud risk assessments, it's where then we proactively identify the gaps or what is it that would impact on the achievement of the outcomes or objectives of the department. And then we both look at internal environment and external environment, and then that culminates in a fraud risk register that we have got in place. And the issue of fraud prevention, where we then look at efforts that assist in the prevention of fraud, whereby we have got all the workshops and the road shows as in the component. Basically, on a quarterly basis, we report on the workshops that have been conducted with regards to fraud risk management, and also on the issue of the risk assessments that have been conducted, and the fraud detection. As much as we would look at fraud risk assessment and fraud prevention, it's also important to know that you can't stop fraud completely. Hence, the detection is important. And then we have got these internal control processes that we'll look at, and also would have the hotlines and the whistleblowing, which will then assist in detecting fraud. Then, when we conduct investigations, it is when we look at ways and we look at how fraud or the particular event has culminated, and then we would come up with recommendations, which will then lead to post-investigative activities, whereby the recommendations will be implemented either through labor relations, whereby we have got a disciplinary action that is undertaken, or we would have other matters reported to other structures like the SAPS or the SIU or the Hawks. Slides 8 to 15, they actually unpack the fraud risk management process, but it's important to highlight that when it comes to governance structures, we also have got the committees that we are accountable to, the management committee of the department, the risk management committee, which is also internal in the department, and the cluster audit risk management committee, which resides within the provincial treasury. And then we have got the portfolio committees and the SCOPA and all the oversight structures that government oversight structures that we would report to, and the importance of setting the tone at the top. With regards to the fraud risk assessment, we did indicate that we are on slide 11 that we do look at fraud risk assessments periodically, and we have broken them down into various components like the SCM, like the HR, like systems. Like in the department, we have got systems management as well. And then it's also important that to note that we have introduced a system whereby we have populated all the risks that would be highlighted by either AG or internal audit, and we have put them in at head office, and we disseminate them to institutions so that the institutions would be able to then come up with the mitigation strategies, so that we have got a risk register that is all inclusive, that talks to the risks that have been highlighted by the other assurance structures. The fraud prevention that we have, we look at as I had alluded to earlier, the identification of weaknesses and control activities, and the issue of ensuring that proper background checks are done by HR, and also the exit interviews also assist in that you would find that you'd be able to get some of the things that are relating to matters that are amiss in the department when we have got aggrieved employees that are leaving the department. And also that we do conduct fraud ethics awareness workshops. that we do have departmental investigation services that conduct internal investigations in the department, and we then we report the outcome of those particular investigations to the accounting officer, where then they would then be implemented accordingly. The fraud detection, we have got the hotline. We have got the National Anti-Corruption Hotline as well, whereby these matters are reported, and we would then be able to carry them out as an investigation, because we don't just go out and conduct an investigation. There is a request that is being sent, or there is a tip-off that is being sent to us for us to be able to carry out the investigation. And with regards to the investigations and post-investigation activities, we then do proper examination. We do have our policies and investigation procedures that we have got in place. And human resources and labor relations are responsible for facilitating the disciplinary processes and passing sanctions on whoever has been found guilty of misconduct. Basically, the legal framework of the fraud prevention plan, we have got the legal framework and the policies and the fraud prevention strategy. The fraud prevention strategy, it then talks to us conducting the risk assessments and coming up with the response plans or the mitigation strategies. And there is an implementation plan whereby we then look at the schedule or the roster on what is it that we are going to be carrying it out that particular financial year, to ensure that we cover some of the areas that are talking to fraud prevention. And with regards to legal framework and policies, we do have a fraud prevention policy, investigation policy and procedures, and we do have a procedure manual, which is our Bible that we follow for us to be able to carry out the investigations properly. Then we also have got a whistleblowing policy, whereby there is a hotline which reports directly to we do receive emails, and then through that hotline we are able to carry out some of those investigations where we find that there is a reason for us to carry on with the investigation. And then we also have got the code of ethics. With that, I would like to thank you, Chairperson, MEC, and members.
Thank you very much. Honorable members, any points of clarity? Honorable Kwanyana, the floor is yours.
Thank you, Chair. Greetings to you. Greetings to the MEC, to the officials and my colleagues. I just want to thank the presentation that was given to us just now concerning fraud in the department. Now, my questions are not so serious to so much, but I just want to know that any cases now that are reported through fraud in the department, if there are some cases, what was the action they've been taking about it? Are they in court or whatsoever? Those people who were found doing this corruption, where are they? Are they still working in the department, or they've been suspended already? I don't know. If they are suspended, are they still getting full pay? Because the cases are still on trial. They're sitting at home, getting their full pay. Who are those people? And again, and we want to see the board, the names of people who are on board concerning this fraud committee. Who are those people that are conducting the investigations in the department? Thank you, Chair.
Thank you very much. Who is going to respond to that, MEC?
Ms. Mwatul.
Thank you, Honorable MEC. Our role as investigation services is to conduct an investigation and come up with recommendations. And those recommendations are then carried out either through labor relations or through court. We do at some stage we are involved with the labor relations where we look at how the sanctions are being or how the recommendations are being implemented, but our role goes as far as conducting an investigation and doing recommendations, and we do a follow-up on the sanctions so that we are able to close on our investigations as what happens. So labor relations would be able to give us an indication as to whoever was found guilty or there was disciplinary processes that were carried out, then they will be able to give us the results of that thereof. And with regards to where matters are with either the Hawks or with the SAPS, we do follow up the matters there. However, you would find that as they are carrying out with their investigations on the side, like for instance, there are matters that we are following up on with the Hawks, but we are reliant on them providing us with information rather than us getting through to them to get the because it's more information that is subjudicate to them per se. So we do we conduct investigations, we go to the recommendations, we distribute to the relevant, send to the accounting officer, and then it gets distributed to the relevant official or structures that would then carry out the further investigations if they need to, or consequence management thereof. I hope I've answered you properly, Honorable Member.
Thank you. Dr. Mthembu, I think will respond to the question that relates to cases in terms of if we know how many are on suspension, is it suspension with pay? Yeah, those kind of questions that way.
Thank you, MEC, and good afternoon, Chair and honorable members. Yes, we do have discipline officials who are misconducting themselves. Some of them are on suspension with full pay. Some of them have been dismissed. Some of them, they will get 3 months and a written warning or 1 month, etc., etc. But I think we can give you a report so that you will know about how many people and what is it that they've done. But we are really very strong when it comes to that. We are dismissing people like no other departments. Thank you.
Yes.
No, thanks, Chair. Yeah, we can provide that report. Some of the cases have been dragging for some time purely because you often find that within the service, managers are not always willing to be chairpersons of DCs to their colleagues. So sometimes they come in, they agree. After a month, 3 months of investigation, they pull out, and then the process starts again. Others are able, for instance, where you have a case of a legal person who's on suspension, is able to utilize all tricks on the book, but your chairperson is unable to, or is not experienced enough to be able to deal with it. So with that report, I think you'll be able to get some of those cases. We have tried to push as much as possible, and in other instances, we were able to say, you are on suspension, but you can be utilized in a different department, because that's a call we made in the Executive Council to say, is it possible that we can swap our managers around, instead of him just sitting or her just sitting at home, the Department of Education can use them in whatever administrative form or social development. Sometimes departments agree to that, but most of the times, even though we had agreed in the executive, but often departments are not willing to take those that are on suspension and utilize in their different. It doesn't mean that they pay them. we continue to pay them, but we just often say it doesn't make sense for us to pay someone who's sitting at home. We can pay that person while the matter is proceeding, but any other department uses them. But we've not really been able to reach an optimal agreement there with the other departments. Thanks, Chair.
Honorable Kwanyana, any follow-up?
Yes, Chair. Thank you very much for the response I got. Now, I just wanted to know about that somebody who found guilty doing that fraud, and he quickly resigned to run away from the department. How do they follow up that somebody?
Dr. Mthembu.
Thank you, Chair. It depends when he resigned, the process. Did we start the process or what? But if we have already started charging or that person has been charged, then if that person, he or she resigns, then we follow that person. And also in the system, we are able to flag the name of that person so that other departments, if they want to employ that person, they will know there is this thing hanging over his head.
Honorable Kwanyana, has your question been, Doctor, sorted out? Okay.
Thank you, Chair. Just as a follow-up on Honorable Nkwanyan, I saw Department of Public Works actually going a step further, putting criminal records against one of their managers. Do the department take that posture because it's something that can be done or that should be done if it's a clear case of fraud or serious misconduct? Thank you.
Dr. Mthembu.
Thank you, Chair. Yes, we are doing same as Public Works. That is why Mr. Mngeti was explaining that we are also involving SIU and SAPS. Thanks.
Yeah, that fellow from Public Works was 1.1 billion rand. It's not a small thing. Yeah. So anyway. All right, honorable members, can we then move to the next agenda item? The honorable members were eager to receive this report on the EMS. We asked for it with a little bit of fervor. So who is presenting this one to us?
Thank you, Chair. Mr. Langa will present on the EMS.
Mr.
Langa, Lona Langa.
Okay.
Yes.
The reason this arose was, you will recall, when you presented your cost-cutting measures to us, although it arose out of transport vehicles, not patient transport vehicles, and not necessarily ambulances that would be transporting patients, we raised concern about the EMS in particular. I must also tell you that as a preamble to this report, that we have made our own findings, and you will see them amongst our resolutions during the festive season oversight visits, particularly our concerns around the EMS. So we'll let you present, and then we'll have some questions for you. So, Mr. Langa, it's over to you.
Good afternoon, Honorable Chairperson, MEC, and Health Portfolio Committee members, acting HOD, and the colleagues. The report seeks to identify or paint a picture of the current situation, but most importantly, identify interventions that as a department we would want to undertake. The first slide talks about the vision and the mission of the department, the legislative framework regulating the implementation of EMS. Also, we're looking at the package of service. But where one would like to bring to highlight is around the national norms and the response time. That the national norms for EMS include that there should be one operational ambulance per 10,000 population. And in KZN, there should be 1,189 operational ambulances. And the current schedule for operational ambulances is 212. This translates to a shortfall of 977 operational ambulances. I need to say that as we go along with the presentation, you will see that we've been buying, procuring ambulances, but we are not adding, we are replacing, unfortunately. The response time, according to the national norms for EMS, also includes that the priority one, which is the red code cases, should be responded to within 30 minutes if you are in an urban area, and within 60 minutes in a rural area. EMS in KZN has yet been presented on the non-performance, non-financials, achieved the response time in 40% of the P1 cases, and in the urban areas, and 45% in the rural areas. We therefore would, next slide, we therefore would like just to share with the committee members the budget allocation in the 3 previous cycle, but we would want just to focus on this note. Yes. Next slide is not there. The budget allocation. But we wanted just to highlight on the COE as it's talked to the shortages at times with the critical staff, and then the goods and services. And it is as it can be seen that in the allocation for 2022-23 it was 1.7, and then in 2023 the allocation was 1.6. And then the current allocation is also 1,786,241. But and the current expenditure is at 1.489. But it is important to highlight that in this, the allocation does not factor in the machinery and equipment, departmental accounts, provincial and government rentals. Right. So the next slide talks to the vehicle acquisition, as it has been reported a number of times that we do have a shortage of vehicles, but we just wanted to display how we have fared in terms of vehicle acquisitions in the 4 previous financial year, where in 2021-22 it was 70 million, 2022-23 90, 2023 63, and this current year is 82,442. And then the yearly ambulance acquisition, we have put it up according to per district how we would acquire the ambulances, and the committee members, including chair, will take note that to the statement I made that we may be buying vehicles for EMS, but we are not adding, because most of them have got a high mileage. So it's more or less like we are doing replacement. Others are involved in accidents, countless accidents. So we end up, instead of adding to the current fleet, but it becomes just a replacement. So the figures are there. And then we also, this slide, Chairperson, is quite important because we did an analysis of the current ambulances per mileage. And you will note that we only have 86 ambulances that are below 150,000 kilometers. And as all of us here who have been blessed with vehicles, you will know that once a vehicle is above 250 to 300,000 kilometers, there is that vehicle in terms of economical value, because constantly it has to go for repairs. And also we have even noted that the increase in the amount of money that we spend for repairs of these vehicles. So we just wanted to highlight that from the ones that are below 150, to the ones that are between 250 to 250,000, and then the list goes up. We even have got vehicles that are below 400,000 kilometers on the clock. One will realize that it's because they are being driven 24 hours, so non-stop. Then the other slide, honorable members, before we come to the intervention, there is a slide where we talk about the aeromedical services. The aeromedical services, honorable members, these are requests which are usually based on a call-out criteria. There is a approved standard operating procedure that lists a profile of patients and conditions that should be assisted. This will include patients' clinical presentation and the level of care that is required. There are cases, honorable members, where a patient may not necessarily fit the criteria, but on the specified call-out criteria for the air transfer. But because of the critical nature of the injury or illness, the delay in road transfer will result in the deterioration of the patient, which may result in a fatal outcome. And therefore, a decision will then be taken to grant the transfer. I need just to highlight that, Honorable Chairperson, we do have a medical officer who interrogates and assesses the submitted request from all the facilities. He engages with the referring doctor and the receiving doctor to the higher level of care. This is done to ensure that there is control within the granting of the approvals for the aeromedical services. It's important to highlight that in terms of the budget, we had allocated 23 million, and we have conducted 107 transfers that at a cost of 7,285,179,058. We just wanted to highlight on this slide the resource allocation, the human resource allocation, with a view to highlight that the staff complement that we have in terms of categories, that we have basic life support, intermediate life support, ECTs, advanced life support, and the highest, which is through a BTEC qualification, which is an ECP. We then, after all what we have highlighted as a department, we've looked at the interventions that we needed to implement. One, we identified 3 key ones that we needed to embark on. Firstly, is to address the issue of the turnaround time for repairs. As Honorable Chairperson has highlighted, the issue of the West Bank, which is linked to the RT46 national contract that is being implemented countrywide from National Treasury. So we've decided we have revived regular monthly meetings with West Bank, focusing on increasing the vehicle repairs turnaround time. But of key, which we felt was the root cause as well on the delay in the repairs, was the fact that we then, following the meeting, especially the one meeting we had in August of last year, after intense engagement, it resulted now in West Bank committing to appointing assessors and inspectors in all the regions, Honorable Chairperson, so that people in Newcastle, in that area, the area up north around Kanyagute, Zululand, and KCD, the one central and down, have got specific assessors and inspectors who will ensure that once a vehicle has been submitted for repairs, the necessary assessor inspections by the assessor, so that we can have an immediate approval for the repair of the vehicle. On top of that, also, we took a strategic decision to appoint roadside assistant mechanics who are providing minor repairs. This also emanates as well, Honorable Chairperson, that when we're doing the analysis of the constant breakdowns, we would identify that a car would be submitted for repairs for a brake light, indicator, wipers, all the minor things, tires. So we then embarked on employing these qualified road assistant mechanics who have been issued with vehicles, and they are appropriately trained and qualified to be able to execute this function, which will ensure that we do not have vehicles staying longer there for minor things. Also, we have to ensure that vehicles with a low mileage are repaired by the original equipment manufacturers, which is called OEMs. And you will understand that as we begin to transform the sector, it was quite important that we had these OEMs and the previously disadvantaged service providers. But we have embarked now, because we've got newer fleet, which require specialized maintenance and repairs. So we have agreed that the ones with a low mileage must go to the original equipment manufacturer, will be your Mercedes, which will be your Toyotas and. So the second one is then the strengthening the fleet management and functionality monitoring. We then we've embarked on a full integration of the EMS fleet into the district fleet management. We've even, Chairperson, ensured that all the necessary asset management from EMS is being transferred to the fleet managers of each district, so that they can take the responsibility for all the fleets that is allocated per district. And then the second part that we've looked at, that we've conducted now, is the decentralization of EMS operational management into the district health service management, so that in each district, the mandate and owners of the district director and accountability, so that all the fleets that are allocated there, they are able to deal with them and are appraised of challenges that can be there. And then lastly, we look at the strengthening the human resource and supervision. We have now implementing the finalization of the organizational structure for EMS, and also of particular importance as well, we realized that we were losing a lot of money on overtime. So we are reviewing the current monthly duty roster that is consuming the chunk of the budget. But we have, in terms of understanding labor relations, it was also important for us to start the consultation process with organized labor through the chamber, and which has then been initiated, so that we do not get a fallout or a comeback where people will want to strike and do not embrace this change. That is all, Honorable Chairperson. I thank you.
Thank you very much for presenting the report, honorable members. Questions? Dr. Mthethwa, followed by the Honorable De Boer, followed by Honorable Nkwanyana. But what we'll do is we'll exhaust one member, then the next, and then the next. Dr. Mthethwa, Honorable Dr. Mthethwa.
Thank you, Chair. Thank you for the presentation. I just have a few questions, maybe 3 or 4. One is around the aeromedical services. It is it's something we saw also on the oversight in December. There's a lot of red tape around transporting a patient, which almost makes it difficult to transport using aeromedical services. And also the cost, it becomes almost 70,000 per transfer, where it generally uses both the road transport and the aeromedical because the landing strips issues. Now, how are we addressing that? Because to me, it looks more as if it's not as feasible as we wish it to be. And also the number of cases that end up being transported against the budget, it looks like we are servicing 107 so far at a quite an extensive amount of money. And then the second issue around West Bank, I see that you've dealt with it. What we've seen the Nyanga Motors, Tuki Motors, it looks like it's a business mechanism that they do, that you'll get a car, then they'll service it, but then within few weeks it will be back to them again. Have we looked deeper into say how can we avoid them benefiting from rebooking these cars quite frequently? And also, okay, with the assessors being per district now, maybe it will be better. And also the other thing is the support, the roadside new team that we have.
Yeah.
Is it a full-time employed by us or it's on tender? That's my question. Then the other question, just the last two, have we looked at as a department in terms of buying ambulances versus renting these ambulances from a service provider? Have we looked at the cost balance between the two and how is that looking? Thank you.
Mr. Langa, over to you. You can respond to the honorable member.
Okay. Thank you, Honorable Chair. I think on the issue of the aeromedical, the honorable member will have noted that I said we have a senior medical officers who then ensures that for every request that is submitted, he interrogates, as a clinician yourself, you interrogate. Then I even highlighted that based on the clinical manifestation, he will then engages with the referring doctor and the receiving doctor where they are going, so that you don't transport a patient who you will find that the high level of care is not ready for them. So that has also assisted us, and we've seen that it has also further reduced the cost, but also ensuring that we save lives. So the issue of the roadside assistance, it was a very innovative way of employing them full time, so that there is commitment and sustainability of the services. I need to highlight as well that one of the things, like you are referring to Onyanga Motors, we are finding that the very mechanics, sometimes they will then go to the service providers to actually check on our cars, because it's better if you take somebody with the same capacity who then will question why this is a problem. Of course, the constant breakdown of vehicles can be attributed to the high mileage, but as a monitoring measure, it's better that we've got these people, these roadside assistants, because they are now working with the fleet management of the district, which make things much easier. We will reap the benefits as we move along, because this is a new innovation. Well, the issue of looking at leasing, there are various permutations as a department that we are looking at, which we maybe when we come back the next time, we will then be able to share. But within our level, I can assure you that we are looking at different permutations, like the one the leasing, maybe using Department of Transport, but we are looking at it holistically. So we feel that once we've crystallized this, we will then be able to take the portfolio committee to confidence about what it is that we'll be embarking on. I thank you.
If I can just come in, Chair, I wanted to speak to the issue of buying vis-a-vis renting. Ngambono Commander wants to run away from that because it's something that we are still working on. Chair, you will remember that in one of our engagements, I indicated that we are exploring an issue of a triple P or any other form of partnership that will ensure that we actually get more ambulances. Chair, we discovered that for us to be able to reach the full capacity of EMS with our funds will take us 20 years to be able to do so. So there is absolutely no way at this rate that we will ever be able to buy full capacity. However, we are very cautious on the kind of system that we get into moving forward with the private sector. There's quite a number of systems that are utilized by different provinces in the country. For instance, the Eastern Cape has a program that the Department of Transport in the province gets into a partnership or buys the ambulances themselves, and Department of Health only rents or only gets them from the Department of Transport, and at no time is there a problem, because that Department of Transport has a responsibility of ensuring that vehicles are available all the time. Another province has a partnership with a private sector, or I think they took the matter out to tender to say, from you, we need 1,500 ambulances at any given time. If you have if we have a vehicle that breaks down, it becomes your responsibility as a service provider to replace that vehicle. However, the costs of the Eastern Cape program and the one that I'm talking to are not the same. Mpumalanga, at some point, Chair, had an agreement with private ambulances to say, and it was a contract to say, Department of Health will provide as far as they can, and private ambulances will provide and then invoice the department. That system became abused in the process. So we don't want to get into a system that we are not sure of. And right now we are looking at all the options. And as soon as we've been able to finalize that, we will inform the portfolio committee. But what I can assure the members is that come the first of the financial year, we will be implementing the new system, whichever system that we get, we feel that it is going to be affordable to the department and will be able to manage. Thanks, Chair.
Dr. Mthethwa, any follow-up?
Thank you, Chair. Thank you, MEC, for the response. I think it maybe I'm defeated if she says it's in the near future that they will come up with, they will decide on one plan that they can use, because I wanted then to say, can't we then look at phasing out the cars that are 400,000, 200,000, sell them on auction, then buy and replace, so that, because those cars, they become like our problem, because they are just there, but they're not functionally there, because you'll get Zululand being allocated 13, but at any given point in time, you get there are 4 ambulances which are mobile. So maybe we should, while we are waiting for a formal plan, get rid of these ambulances and buy new, replace them. Thank you.
Any response?
It will be part of the consideration that we make, Chair.
Thank you. Anybody else? Honorable De Boer.
Thank you, Chair. I'm partly covered by Honorable Mthethwa's questions. Just want to raise the fact that we have 212 operational ambulances in the entire province. For me, that with the shortfall of 977 vehicles is a crisis of sorts. Concerning for me is that the response is 30 minutes in urban areas and 60 minutes in rural areas. I can tell you it looks good on paper, but certainly not in practice. We had a case in Durban North where there was someone that was very sick and we called an ambulance, and 2 days later he died, still waiting for the ambulance to come in and give him assistance. So I think the ambulance response times are not as they reflected here on paper. And I think we kind of do have a crisis of sorts when it comes to the amount of ambulances available in the province. But thank you for these interventions. I certainly hope that we're going to see some progress in terms of response times and having more ambulances available to to the communities. Thank you, Chair.
Thank you very much for that input and for your comments. I'm sure the department is noting it. So I'll have a few things from my side. So the first thing is that in the regulatory framework, the Health Professions Council of South Africa is requiring that there is a migration of qualifications upwards. And what I would like to see is an expansion of this report at our next meeting, where you will tell us about your staff that you have in the department and how that process is being undertaken. Now, with regards to the financials, up to the second quarter, the challenges, I think it's program 3, on the EMS, the challenges are noted there. But we still want to look at the budget for this for this particular program on emergency medical services. My recollection is that, you know, I'm serving on the portfolio. I mean, I was here from 2014, and we have been banging our head on the wall, particularly around the budget, in that it has never been sufficient for EMS, to the extent that at some point I even called it the stepchild of the Department of Health, because you know, we do so many other things, and EMS, while it's as essential as it is, seems to fall by the wayside. So I'm saying that let us look at it, and we are in the budgeting cycle. And I know that you embarked on a zero-based budget at some point, but I'd like to understand the budgeting around EMS more. Now, I think we can only do that because the MEC has committed to saying, look, there is going to be a new system, and in the new financial year, we are going to embark on another model. The thing is that we'd like to be taken into confidence, and you tell us before that time what that new model is that you're thinking of. If we think of something, we'll also let you know. So if the portfolio says, look, I'm just choosing a country randomly. I don't think Rwanda is a good example to use right now. No, I'm just joking. But I'm saying perhaps there's somebody doing something innovative on the continent. Perhaps in the Far East, where they have similar challenges to us, like Thailand, or India, or Pakistan. Are they doing something innovative? Now, I think we need to look at these models and not be hasty. I know we need to do something, but I think we need to embark on models. We're looking at other provinces, yes, but all of these provinces have the same challenges that you do. They don't have a different challenge. Their challenge is no money, the same kind of terrain, same kind of population, like, you know, Gauteng, perhaps maybe the Western Cape, slightly different dynamics. But the terrain in the rest of the country is very much the same. So, you know, so I think we need to give it a little bit more thought. I think maybe, let me see, we don't have money to go on a study tour. Maybe your department has money to send you somewhere to have a look at a model. I don't know. But there's no money as we see it. But we need to examine other models. So I think instead of hastily, you know, going headfirst into a shallow pond and say, look, we're going to do this, and then we sit here, you know, 6 months down the line and say, hey, you made a mistake. So I think we need to really look at that. So I think in terms of budget in a new system, I think there needs to be an alignment. So that is something we need to look at. Now, the Honorable Doctor has raised the questions around the aeromedical service. I also have some questions for you. So who provides your aeromedical service? I don't know, because my recollection is that the AMS used to provide it. Sorry, what was that? I can't remember the name of the company. AMS, yeah. So AMS used to provide that service. They no longer provide it. So who provides it now? And what was the reason for not using the AMS? Because the aeromedical service, when AMS provided it, allowed for other things. One is it allowed for outreach programs. So, you know, doctors from Gray's Hospital used to go to Madedeni Hospital, for example, and perform procedures. So I'm not sure if that is still something that is part of this contract. Maybe you can enlighten me. I must tell you that in our engagement during the festive season oversights with the doctors in hospitals, they said it's quicker to drive there. So the red tape that Dr. Mtetwa spoke about was very real. So red tape, I understand there needs to be stringent measures because of cost. That's why I'm asking about the comparison between the service that was provided and the comparison, and of course the service that is provided. What's happening there? Because if doctors, and one of the doctors said to us, I think it was at Fred Hospital, I think they did a presentation to us, they said that we are attending to a critically ill patient, yet we are the ones that are supposed to be involved in liaising with the person in the province to make that decision. It takes away time from critical care of a critically ill patient. That is concerning. Now, if anybody's worked in a hospital environment and you know you've got a red coat patient that you're dealing with, a critically ill patient. Now, the clinician that needs to take time away from the care of the patient to make phone calls and have conversations and things like that. So I think, I'm not saying that I want an answer from you, but I think there should be an engagement at that level between yourselves and those that are providing the service at the ground level versus what is required of them to try and find a way through. Because we don't want to see the service or the red tape that is in between as an impediment to get the patient to be seen in the manner that they need to be seen. So if the patient needs to be taken to Gray's or Albert Lutuli or wherever the patient needs to be transported to Mbwelezana, to King Edward, wherever the patient needs to go to, because they need that higher level of care, there must be no impediment in that way. So that's the other consideration. Now, MEC, I spoke to you about this informally, and you were correct, and you'll correctly say the same thing again, that policy around the routing of the ambulance is not a provincial competence. It is something that was decided on nationally, and I'll give you an example again. So we went to Seleni Hospital because we were looking at the N2. So they tell us that their patients are taken from the Hluhluwe clinic. If there's an accident on the N2, patients are sometimes taken to the Hluhluwe clinic. The patient is then transported. The patient needs to be at Ngwelezana. But what they do, because of this red tape, if we can call it such, the patient has to first go to Mseleni Hospital, it's 100 kilometers away, seen there, and then transported another 200 kilometers to Ngwelezana Hospital. So that clinic can't send them straight there, even though that level of care is required. In other words, you're delaying urgent medical care and the patient can die. Now, this is not something that you can fix. I'm just alerting you to the problem. The MEC and I had a conversation, and it's something to take up with other MECs, because you are not the only one that has the problem. So when you meet with the minister and you meet with the department and you meet with the director general, you could say, listen, KwaZulu-Natal needs a deviation from this, or how can we do this? So this is the kind of problem. So the patient, and then we were supposed to visit another hospital, but we didn't go there. We said, let's go and see this Hlotlowe clinic. We went there. Now, if I was working at that clinic and I saw a patient with polytrauma that ended up in that clinic, I wouldn't be able to do much. So I'm making a suggestion. Have a look at it yourselves. Go and visit that clinic and probably equip them a little bit more. They might need a little bit more equipment to do a little bit more. Just to give you an example. So in examining these routes, we need to look at these shortfalls. This is our, I don't think it's equipped enough to deal with trauma. It's a clinic. It's not supposed to, deal with a patient with major polytrauma. But at the very least, they should have the equipment and the drugs and the life supporting systems in place to at least stabilize that patient in a manner that the patient can be transported further. But that business of them going to Mseleni and then going to Ngwelezana, not going to serve. And that N2 route is a very busy route. And it happens that clinic ends up. Now, on the EMS and on that N2 route, I must tell you that we would, I couldn't quite get this information, but I'll leave it in your hands, MEC. They told us this at Ichelo that they have an excellent working relationship with the South African National Defence Force, in that the SANDF ambulance service renders a service to the province with their ambulances when they are needed. They have some arrangement amongst themselves. So if you have, if at all possible, perhaps through your office, a word of gratitude and congratulations to them and thanks to them for rendering that service. It is indeed something they don't have to do, but they do it anyway. It's one state, IGR and all these things. So perhaps something like that. I tried to get the details of the commander of the base, but we couldn't get too far away. We said, okay, at least as the portfolio committee, we'll write to them and express our appreciation for extending that services to the people of the area. Cost of repairs has been covered under Dr. Tetwa. So I think those are my queries and questions and suggestions on your report. And I think that we're not done with this report, because obviously we want you to come back to us. We can't say that we've dealt with emergency services. We're far from dealt with it. So you've highlighted your challenges, you've listened to what we're telling you, and we want you to come back in the next meeting to us and tell us what you're doing about it. Because if we don't constantly deal with this issue, we're not going to get anywhere. And in that report, obviously, we want from you any suggestion that you may come up. Honorable members, if you can explore through any research method, our committee researcher is not here, but when I had a meeting with the committee staff, which is a meeting aside from the committee where we plan the activities of the committee, we will increase our oversight over the EMS, and we said that we've tasked our researcher to also look at possibilities of looking at other systems. So if we find something as the committee, we will be more than happy to share it with you, and therefore the need for the interaction at the next portfolio committee meeting. Mr. Langa, over to you for any responses, acting HOD, MEC. MEC, I'll leave it to you to direct your team in case there are remarks you wish to make first.
I think Mrs. Msnot. Thank you very much, Chair and honorable members. Maybe one would want to explain the service providers first. For aeromedical services, we have a panel of 2 service providers, which is Netcare and AMS. But most of the time, AMS is not available when they are on call out, and I don't think No, no. Um, yeah, I think their aircraft is not maybe up to a certain standard, because sometimes when we make a call, particularly in bad weather, they are the ones who are more often decline, whereas the other service provider would agree. Maybe also let me clarify that what we found when we put in the systems is that sometimes, yes, clinicians will complain that the process may be tedious. Hence, Mr. Lang, I was saying we've put in a clinician, a doctor. Doctors always usually trust other doctors. So we felt that let's put in a doctor who will actually immediately engage with the clinician who's transferring the patient. Because sometimes you might find that when you establish the reason for the transfer, this patient could have been transported by road, and you check maybe with the referral hospital in Kosalpet or Ngweleza, and the doctor at Ngweleza or in Kosalpet would say, no, I didn't say this patient must be airlifted. Or I'll give a classical example. At one point, the doctor wanted to transfer a patient by air between Tunjambili and GJ Justice Gizenga. And it would have taken an hour or so for the aircraft to pack, to go up from Virginia, go to Tunjambili. In 30 minutes time, that patient would already have been in Justice Gizenga. So it's such things that we make sure that we don't incur wasteful expenditure just because we are now flying everyone. But we make sure that every patient that requires to be airlifted gets that service, particularly in rural districts like Zululand. They are the most who use the service, Zululand, Mkanyagude, and Herikwala. But we make sure that we are as cost effective and efficient as possible in that one. The issue of the Tlhotloe clinic, I think we will investigate it, Chair, with DHS, because maybe it's the issue of the referral pathways and the profiling of the patients. We will provide a report on the budgeting alignment between the new systems that we want to explore, as well as the budgeting process. And also, one other area that we wanted to do, and we've started actually engaging the partners, we wanted to do an efficiency analysis over EMS, get an in-depth interrogation of all the aspects of EMS provision in the province. We are starting to look into how that could be done, to do an in-depth, involved efficiency study around all aspects of EMS, human resources, vehicles, how the vehicles are put, and so that we get a report that will inform any model that we are going to implement. Thanks, Chair. I don't know.
Thank you very much. Any other input?
I don't know if Dr. Moji wants to speak to the issue of the referral pathways between the clinic and Bethesda and Ngwelezan.
No, thank you, HOD Chair. I think the Chair has already said it's for the MEC to discuss with her counterparts, because this seems so. Maybe let's leave it at that for now.
MEC, over to you.
Chair, there's a distinction between aeromedical and flying doctor service. There are two distinct services. The aeromedical is purely for patient care, which is what they have. The flying doctor service was specifically for outreach purposes, and their funding sources and issues are completely different.
Yeah.
Yeah.
Now,
That's the distinction.
okay. But what I was getting at was, I recall that the service, even that distinction exists in terms of funding and so on, and the outreach program, but the service provider was AMS. And so I was trying to get at, where are we with that? Because what I mean, I'm not saying it is factual, but you can respond to it by telling me, the outreach programs, how are they going? Are you using the same service provider? Even though it may be different, the overlap is because of the service provider.
Thank you, Chair. We are still using AMS for the outreach program. However, between ourselves and AMS, we now source funding externally. We go to donors. Sometimes they go alone with a letter of support from us and where we get, and that's how for the past 2 years we continue to run the service as a donor funded, whether we get money from the lot or whether. At the end of the day, it's also in their interest for the service to run. They have pilots, they have aircrafts that they have to pay, whether they get utilized or not. So we go with them, but that's how we've been funding it because of our own funding constraints.
Okay, that is helpful. Thank you very much. MEC?
No, thank you, Chair. In terms of the pathways, definitely, like you said, it's a national matter. But what we have done amongst ourselves, and there's quite a number of examples, Chair. I think at some point, I don't know if I raised this matter with you. EGJ Crooks is closer to eThekwini. GJ Crooks, ne? Yeah. GJ Crooks is closer to eThekwini and has a lot of people who actually would just walk to GJ Crooks than it is Potchefstroom. And we received a lot of complaints about 2 or 3 years back when people were saying, look, the hospital is just here. And every time I go to that hospital, they tell me to go to Mshieni. And it's just not practical. We then put the team together to say, but we are one department, we are in the province. Does it make sense that a hospital that is across the road from me, I can't access? And the management amongst themselves made a proper arrangement, because it's referrals are national, but referral pathways are national. But we then made an arrangement amongst ourselves to say, this community of Manzimtoti, I think it's the Manzimtoti area, should actually be serviced by a GJ Crooks because it's just a walking distance away. So we have done so in a number of areas. I think it's a matter, this one, while I will be talking to national, but it's a matter that amongst ourselves, we must be able to go back and call the management of EMS and the facilities to say it's not practical the way they are managing, and we just to make another arrangement amongst ourselves. But I do want to emphasize the arrangement part because it's not something that we have control over. However, we realize that people are in front of us, and people like it makes sense. And I was wondering why you were saying this clinic must be given the equipment, but I hear what you are saying. It's on the road, and when there's an accident on the N3, they are the first health facility that should be providing some service. So ordinarily, that's equipment that would not go to a clinic. But because we are running a province and we understand our challenges, we might want to look at that. So we will explore the proposals that we are making, Chair, and see how we implement them.
Thank you very much. MEC, look, we would want to follow it up. We have taken a resolution in that regard. It's in these documents. And I think we'll emphasize it as a resolution of the committee to revisit that with you in 6 months. Is that reasonable? 6 months to review the upscaling of equipment that Polani will put it at Lutluwe Clinic, right? Honorable members, we are now quite time bound. We were supposed social development takes over at 3 o'clock from us. So I'm going to just quickly manage this agenda in a different way. I will consider the matter on EMS complete for now with the resolutions that have been taken. I will ask that the presentation on traditional healers is tabled before the committee and that we consider the report, and any interrogation is taken forward to the next committee meeting, but I will consider it tabled. Honorable members, may I have somebody table the report? I table the report. Anybody to second that? Done. There is a presentation on our resolutions. The resolutions are here. These resolutions were taken throughout a period of time. They have been sent to the department and they have been responded to some extent. That means that all are not complete because some are pending. I've been looking at them. Some need a little bit more information. Some have been concluded, and those reports that have been concluded have been sent to us. So, MEC, you wanted to come in there?
Yes, Chair. Chair, in fact, we're going to make that request ourselves to say the matters that we have submitted to you, most of them are in process and we require a bit more time to actually investigate fully. So if our next meeting, some of them, you can have a proper report, Chair. Thank you.
Thank you very much. So I will consider those in progress. Kolani, you wanted to advise me on something? Traditional healers by the department. Okay, I'll come back to it. Kolani is advising me on procedure. I'll come back to the procedural matter just now. So the presentation on the resolutions is noted, and we'll come back to those items that are pending. The department will be given the opportunity to respond to each one of them. There is a presentation here on patient cases. Now, what happens is that we receive a lot of complaints as the committee. So what we have done, instead of just sending that off to the office of the MEC or HOD, we decided that the committee will track these complaints, because what is the use of us receiving complaints and sending it to you, and then what? So what has happened is that we have a document here, and you have seen it because you have received it, is that as we receive responses from yourselves, we present it here. If there are any pending issues, it also gives you an idea that there is a pending issue which you need to attend to. So I will consider that item as noted on patient cases. I'm going to come back to the traditional healers one, because that is the matter of procedure. Kolani advises that the department needs to table that one.
Which?
7.4. It's not on your agenda. Maybe you didn't receive that one. It's on my agenda, and the document is here.
Yeah.
So it was sent to us. We had received. I'll tell you the history very quickly. We had received a request from a group of traditional healers who wanted to meet with the portfolio committee. But we thought that instead of meeting with the portfolio committee without the portfolio committee being appraised on we thought that before we engage with them, we should know what the relationship between the department and traditional healers is in a formal space. And then, of course, we have a basis on which to engage with them. They had no complaints. They just wanted to engage with us. So we've requested a presentation. It is here in my file and folder. So you have sent something to us. So we don't want to engage it now, but we want you to table it. So probably the acting HOD, we We will ask you to table it and we'll accept it. So you need to, for the record, say you are tabling the report.
Thank you, Chair. The department would like to table the report on the traditional healers. Thank you.
Accepted, members? Honorable members, do we accept? Table, so table. Thank you very much. I think that then takes us to, there is an item on the agenda, discussions and resolutions. All the resolutions that we have taken so far have been duly noted for which we will send to you. The reports that we require, the things that we need so that you can prepare your responses for the next portfolio. We will be meeting on the 11th again. And on the 11th, when we meet, we will be here in Pietermaritzburg. We will be visiting, sorry? Yes, 11th of this month. So what we will do is we will let you know. No, it's oversight visits. So we wish to visit facilities. What is outstanding from our side is during the festive season oversights that we did have a presentation from Northdale Hospital. They met us at Grace and they gave us the presentation. The walkabout is short or missing from that part of the engagement. So we will be going to Northdale. But I didn't want to bring members all the way to Pietermaritzburg to go and walk around a hospital for 15 minutes or half an hour. So we will be extending an invitation to 2 other facilities. We will notify you. We have chosen 2 facilities. The first being, I think it's the East Street, what is it? East Street, Boom Street Clinic. Yeah, East Boom Clinic. And the other is the Fort Napier Mortuary because, forensic pathology services. So we would like to engage with them as well. And so we will meet them at for their presentations at Northdale Hospital, and then we'll go and do the walkabout at their facilities after that. So those are the matters that is what we will do on the 11th. Honorable members, is there anything from your side? Polani, am I missing anything? No. Honorable members, any last take on any matter? We've got 10 minutes. Ms. Matite, are we missing anything? Nothing? I can carry on. We've got a lot. Dr. Moji is very tired. He's muttering there. Okay, if there is nothing else, honorable members, that brings us to item number 9 on our agenda, and that is closure. This was a marathon meeting. We would have liked to engage a little bit more with you, but everybody's rushing me. So thank you very much, MEC, for making yourself available for this meeting. Acting HOD, CFO, and all officials of the department, to the honorable members, colleagues from the legislature, and committee support staff. Thank you very much, members online. Thank you very much for your time. The meeting is closed.